Handa from New Delhi, and may I invite the two gladiators to join me upstage, Dr. SAPAN PANDYA from Ahmedabad and Professor LIZA RAJSHEKHAR from Hyderabad. I don't see, oh, there he is. The motion before the House today is cyclophosphamide dying a natural death. For the motion is Sapan Pandya, and against the motion we have, no, I think we'll have a buffer between the two gladiators. And against the motion is Dr. LIZA RAJSHEKHAR. The proponent and the opponent would have 20 minutes each, and then we will have, the first person would be Sapan, 20 minutes, then we will have LIZA, then we will have Sapan giving a rebuttal to LIZA, and then we'll invite questions, comments from the floor. We get started. Over to you, Sapan.
So I think Yojana is in. You want the audience to first give the vote, or okay? Respected chairperson, my co-debater, my teachers and seniors in the audience, and friends, I have been asked to speak for the motion, which means I'll be speaking against the drug. And before I start, I want to say this: कि हमेशा देर कर देता हूँ मैं। बदलते मौसमों की सैर में दिल को लगाना हो, किसी को याद रखना हो, किसी को भूल जाना हो, हमेशा देर कर देता हूँ मैं। And so friends, Indians, countrymen, lend me your ears. I come to bury cyclophosphamide, not to praise it. And I'm reminded of this particular from the Emperor of Melodies, that when data doesn't meet dogma, match dogma, believe data. And so what I'm going to do in the next 15 minutes or so is to try to show you all the data that I have covered, tried to cover against the use of this killer drug. So ladies and gentlemen, and I have about 20 slides, so it'll tighten your belts, and as Captain Sully said, brace for impact. Now I can't help comparing the analogy to, there was a time when cyclophosphamide was really good a drug and it was used, and then came a time when other parties started creeping in, and there was even further reduction, and now you know the situation, and I doubt if there is anything left with cyclophosphamide, but I'll try and prove that in the next 15 minutes. So this is for the postgraduates and the early rheumatologists. The first, and this was a bastion for cyclophosphamide, but the problem was that they are not sure in themselves whether the oral one is useful or the intravenous one is useful. But anyway, so this is a diagnosed case for 7 years with irritation in the left eye, redness and burning, deforming arthritis, seropositive. So this is what we call a corneal ulcer. And when you carefully look at data, and this is from the conclusion from a review which was there, and in general, patients who have PUK, which means peripheral ulcerative keratitis, associated with rheumatoid, will be managed in the first instance with high-dose steroids. Methotrexate may be added. You may add a calcineurin inhibitor. And so cyclophosphamide has been effective in treating PUK, but it is less commonly used now. More patients have access to biologic agents like anti-TNF rituximab. There was some more data from ANCA-associated vasculitis from GPA, but at the moment we are talking about rheumatoid arthritis, so I'll stick to that. And this was from the same review, data on the use of rituximab, and as you can see that it improves corneal melt, and that's how it has almost replaced cyclophosphamide as the new drug for corneal melt. The other state or condition where cyclophosphamide was very useful is rheumatoid interstitial lung disease. You have a UIP pattern on the CT scan, an FVC which is quite low, and most of these patients would again be seropositive. What is the data there? So no formal control trials for cyclophosphamide rheumatoid ILD. Limited efficacy, very important to know. These patients have joint pains as well, and cyclophosphamide doesn't work for joint pains. So mycophenolate is an alternative to cyclophosphamide as first-line agent. This was again from this particular review. And clinical improvement and stability of function and radiologic assessment in patients with RA-ILD in another retrospective study, which was again quoted there below. The forced vital capacity and diffusing capacity of the lungs for carbon monoxide, that also was retained with MMF. And while you can see in the table that the number of patients are more with cyclophosphamide, there is some more added to this with our Indian data, and mycophenolate works as well as cyclophosphamide would be the preferred drug simply because of the toxicity. This is data by Paul Emery's group, where he has shown that rituximab leads to about 200 odd patients, and the 154 is the stability. So it leads to stability of ILD, and we all know that stability in interstitial lung disease with the UIP pattern is as good as improvement. I'm sure all of you have by now gathered the analogy between cyclophosphamide, rituximab, and I'm not even going to discuss about JAK-inhibitors, which might still have a better future. This is just. And so for talking about some other states, going further east, this is long-standing rheumatoid with joint pains and morning stiffness, non-healing ulcer over the left leg, foot drop which suggests monocyte multiplex, again seropositive patients, rheumatoid vasculitis, you do a biopsy and you find that, again a bastion for, used to be for cyclophosphamide. What is the data there? Again for skin ulcers, you could use cyclophosphamide rituximab, but for monocyte rituximab is preferred. I'm sure there are local therapies, all of you know about lesser invasive therapies for cutaneous ulcers. Rituximab is preferred in the younger patients for obvious reasons. Those with renal problems, cytopenias, and high rate of malignancy. This is from the French autoimmune and rituximab registry, where they've shown 17 patients' data, and about 70 to 80% had response and lower mortality when compared with cyclophosphamide. So even in rheumatoid vasculitis, most of us have started using rituximab now. And in fact, when you talk to the juniors and you talk about cyclophosphamide, they actually look at you as if you are from the era of Columbus. Talking about another condition, going to the next state, which was lupus nephritis, was now almost taken over by the other drugs. A young lady, just married, so again she's going to have her family. 6 months of palatal ulcers, polyarthralgias, urine showing active sediments. This is lupus nephritis proliferative. What is the data with lupus nephritis? So these are the ACR guidelines. As you can see, cyclophosphamide is shown in stars. There are only 4 stars here, whereas if you count the other ones, you have 1, 2, 3, 4, 5, 6, 7, and 8 positions are occupied by the other drugs. In maintenance, we all know there is no role for cyclophosphamide. In induction, you might use, but mycophenolate is as good, and that was first proven by the classical ARMS trial of 370 patients, where the response was almost equal, 56 versus 53%. And the Cochrane analysis, meta-analysis of 800 patients showed that the end-stage kidney disease, mortality and relapse, complete response numerically higher in MMF and less alopecia. And all of you know that Cochrane is something sacrosanct, like Dr. Amita Agrawal or like Vidyut Das, they always speak the truth. And you have some more data from Southeast Asia, where you have mycophenolate mofetil and CNI inhibitors versus cyclophosphamide. Again, this is complete renal response. That's partial plus complete, so overall renal response. Look at the figures, the differences. Another Chinese study, which again showed, we all know that in Southeast Asia, CNIs work very well. There is also data from this Miami group on the maintenance and 6-year follow-up survival, event-free survival, renal survival. The difference of 90 versus 45% when you give mycophenolate both as induction and maintenance, or maintained with azathioprine versus cyclophosphamide use. And also the fact that the latter had more infections, amenorrhea, relapse rate was also high with cyclophosphamide. The NIH protocol has already died. It's natural death, all of you. I don't think any of us use that. And I was talking about the Southeast Asia and the Chinese studies. And you know what happens when you don't listen to China. We've recently seen this. And this is some Indian data. That is Nepalese study, because you don't find much Indian published data. And you can see that all the 3, they've used the NIH, the European lupus nephritis, and the MMF protocols. And you can see almost similar rates of remission 71 versus 65 versus 72 on the complete remission rates. And this is from very nearby where my co-debater is going to speak, from Telangana, and about 144 patients showing similar response with cyclophosphamide, whether it is 24-hour uniproteinuria, change in proteinuria, or creatinine levels. So when the two are equal, you obviously select a drug which is less toxic. Coming to other areas where cyclophosphamide was not much used, you have again very low quality evidence. This is from Cochrane again, that cyclophosphamide is more effective. And they clearly write that from our point of view, and this was even before rituximab came, there is no evidence to support one or the other regimen. Azathioprine may be a better option due to its better side effect profile. And then there is some small Japanese studies and other studies which have seen responses to the tune of 85 to 100% with the use of rituximab in neuropsychiatric lupus as well. And we all know that we've almost substituted cyclophosphamide with rituximab in all these cases. What about scleroderma? 45-year-old lady, 3 years duration, and this is a higher ordnance score, CRP which is high, and look at the lung. I'm not going to bore with the SLS1 and 2 studies. These are the ACR, the guidelines by Dinesh Khanna. And while, I'm sorry, can I go back? Yeah, so, and you can see here that the clinical interstitial lung disease, although cyclophosphamide has been included, is way down number 3. The first is MMF and then others, and even in, of course, the subclinical IRD, you don't use cyclophosphamide. So, and very importantly, he has written here that although cyclophosphamide has randomized control trials, we prefer to use rituximab for reasons of the side effects with cyclophosphamide. So that is clearly stated there. The SLS1 study, we all know that these were the differences, and then cough was one of the outcome parameters. Now, cough is so subjective that you can get well even with warm water goggles, you know. I mean, that is hardly an outcome measure. And when you look at SLS2, then of course we all know that the improvements were similar, but there were more deaths and withdrawals and failures with cyclophosphamide than with MMF. The meta-analysis, and earlier some studies, the meta-analysis did not confirm improvement PFT with cyclophosphamide. Some randomized control trials also done earlier, while it did show some improvement, it was not clinically significant, and the other parameters did not improve with the use of cyclophosphamide. So these studies have been ongoing since quite some time. And then we have our own IRA's Shashi Tharoor's data. And mind you, there is no semblance to the recently concluded elections. This is just based on his appeal and charm that I call him Shashi Tharoor. And he had about 54 odd patients, where again he showed that the use of cyclophosphamide and MMF were similar, and that there were more side effects with the use of cyclophosphamide. They've almost shifted to MMF. There is some more data from the East, from Dr. Alakendu's group. Mind you, madam, there is no resemblance to a phenotype here. This is just to show that this is from Bengal. And again, they showed that rituximab and cyclophosphamide were similar, and therefore that rituximab would be a second and a better option to cyclophosphamide because of its lesser side effects. The reason I'm not entailing side effects is because that is, very well known, as well known as the sun rises in the east. And I'm going to have just one slide on that. Coming to more volatile areas, 30-year-old gentleman, this is GPA or vasculitis with active sediments. This is GPA because of the PR3, and you can look at the shadows there. And what do the ACR guidelines state, which came only last year? Again, here you can see clearly the written rituximab preferred over cyclophosphamide in active severe GPA, and in the non-severe GPA also on the top is glucocorticoid plus rituximab, and only when that doesn't work in the other areas, cyclophosphamide is reserved for patients who, for some reason, you can't give rituximab or that they don't respond to it, and we know that, again, these are going to be very difficult cases. So this is what the guidelines say. These are the eGPA guidelines. Again, look at, you could use cyclophosphamide or rituximab, but because if the effects are equal, as I said, you would choose the lesser devil's alternative, which is rituximab for reasons of side effects. And a non-severe GPA score you could manage with, and I'm not even talking about drugs like mepolizumab which have come. What about, of course the RAVE and the rituximab trial have been discussed often in the last 2-3 days. We know that in relapsing disease that rituximab is definitely better. This was a study which was to prove that Ritux is non-inferior to cyclophosphamide, and now we all know that it is actually superior. Even the recent study came where above 75 also they found that rituximab was safe, and 86% achieved. This study has just come, I think. Yeah. And earlier also some more studies where they showed that you don't even need to add cyclophosphamide to rituximab for induction, only in very rare cases because of higher mortality when you add cyclophosphamide to the regime. And even when maintenance, there was a study which showed that azathioprine and cyclophosphamide were actually equal at the end of 18 months, and there was no difference between the two. What about Indian data? So that is some Indian data of our worry for using rituximab in AAV. This is data from PGI Chandigarh, where their group has shown that including rituximab they've given, and that has not caused any problems. There was some more data that was looking at the PGI data where they have used rituximab in COVID also. This is earlier Hinduja data in 2014, where they showed that cyclophosphamide was used in 60%, but there were relapses were common, about a fourth of them actually relapsed. And this is data from my own co-debater LIZA RAJSHEKHAR and her group, which showed that ocular presentations actually responded and there was sustained remission with the use of rituximab. And this is Takayasu guidelines, and I'm sorry, but you can't even find cyclophosphamide anywhere there. So this is the status of cyclophosphamide. I'm not even talking about the side effects. We all know the side effects. The infections in different series have ranged from 30 to 40%. We've all had our own graveyards with the use of cyclophosphamide in our patients. Infertility, again, ranging from about, on mean of about 19% in some series, but depending on the age of the patient, effects of cytopenias, hemorrhagic cystitis, cancers, again, about 10 to 13% of cases, myelodysplastic syndrome, and these malignancies, second malignancies can be really incurable and cause deaths in most of these patients. So these are the side effects. I've not even gotten the details of the side effects of these because they are very well known. And therefore, ladies and gentlemen, in today's times, what are the options to cyclophosphamide? You can use rituximab with or without methotrexate or even leflunomide. All of them are equally good alternatives. There are some other options also that you have in place of cyclophosphamide. There are some who have come and gone and they keep coming back again. And I'm not even talking about some of them, as I said, which could be the future. And then there are some which are new and seem to be quite promising. Again, they might come around as alternatives. So even when you use Mesna, I don't think cyclophosphamide is going to work. And they have now come with this new option, it's an old drug which I don't think is going to do any wonders. Even that I don't think is going to work in most of these patients. And so even after all of this, if you were still to use cyclophosphamide, then I cannot but help quote this quote from, this guy is a medical futurist from Stanford, and he writes that I think I might tell my children in 10 years that the early 2010 was a barbaric era. And if we continue to use cyclophosphamide, I think I'm afraid that is something that we'll have to tell our own children. So at the end, I would just like to say that इज़्ज़तें शोहरतें चाहते उल्फतें कोई भी चीज़ दुनिया में रहती नहीं. आज मैं जहाँ हूँ वहाँ कल कोई और था. ये भी एक दौर है, वो भी एक दौर था. And I request all of you for the next 15 minutes when my co-debater speaks to maintain silence as a mark of respect for a drug that has served us well for all these years. And may the soul of cyclophosphamide rest in peace. Thank you, ladies and gentlemen.
Well, thank you very much, SAPAN, and I think SAPAN's arguments have taken us through the political landscape of the country. And for the foreign delegates or the speakers who joined us, this is the kaleidoscope of Indian politics, contemporary Indian politics, and whether this will be a Bharat Jodo or a Bharat Todo Yatra, we do not know. Let's now hear the worthy opponent, Professor LIZA RAJSHEKHAR, rising in defense of the grand old molecule of rheumatology, cyclophosphamide.
Good afternoon, everybody. And SAPAN, I must say that I thoroughly enjoyed the brilliant color of your first slide. It is my favorite color. And I must also admit that you understand politics way more than I do. But I hope that by maintaining pin drop silence in the next 15 minutes, the audience will understand the science behind why cyclophosphamide is not dying its natural death. Can I, where's the click? So, death is anything but extinction, and SAPAN seems to try to push cyclophosphamide off this huge stage. But I think, as the Bhagavad Gita tells us, and for the foreign speakers, this is one book which guides us through daily life, which everybody here probably agrees with. Death is a meaningful departure. The rules of engagement have actually been very fairly set by SAPAN, and he's talked about only those areas where cyclophosphamide is a good contender. But I'm not sure whether you came to bury cyclophosphamide, but you seem to be praising rituximab too much. So was there nothing else? And I'll also use the same rules. I'll compare cyclophosphamide with only drugs approved in these diseases, and I will not talk about cyclophosphamide and its cost, because that, as you all know here, who treat patients in tier 1, 2, 3 rural areas, will be absolutely an unfair advantage to me. I would like to take an audience poll here. How many in the audience think that steroids are dying? At least one hand? No? But look at the literature. We are talking about what is the right dose of steroid to use. And it is profoundly encouraging that each positive trial in the last year has used lower and lower doses of steroids with good efficacy, and that the induction therapy for lupus nephritis with no added oral steroids, obinutuzumab, will finally address this issue of whether steroids are dying. And we all know about the rituximab trial, which showed us that yes, you can work with lupus nephritis without steroids, but yet nobody believes that steroids is dying. Now, this is the algorithm for treatment of newly diagnosed or relapsing ANCA-associated vasculitis, and I agree with SAPAN that cyclophosphamide is one of the many. But look at where it is. It is a standard of care, it is in the newer perspectives, and the evidence for rituximab, if you see the hashtag, is supported by lower levels of evidence, and some of the other drugs are still being tried in trials. So are we going to really push cyclophosphamide off now? The RAVE trial, you did mention that, it compared rituximab with oral cyclophosphamide for remission induction and said that it was effective, as effective as continuous conventional immunosuppressive therapy with cyclophosphamide and azathioprine, and it maintained remission over 18 months. And adverse effects were equal, and both did equally well in diffuse alveolar hemorrhage, renal disease. Both the treatments did very well. Cyclophosphamide didn't do badly. Rituximab is not without its problems. The rituximab trial took severe new renal ANCA-associated vasculitis and compared it again with cyclophosphamide. But do you know, SAPAN, that all patients in the rituximab arm received at least 2 doses of cyclophosphamide, and that many of them received 3, 4, 5, or even 6 or 7 doses of cyclophosphamide, and that led to the critical question in an accompanying editorial that whether cyclophosphamide should or should not be used in conjunction with rituximab for the induction of a relapse-free sustained remission in AAV, which is a disease which is bad and which is known for its very high rate of bad relapses. And so you fast forward from 2010-12 to 2018, and you're still talking about combination therapy with rituximab and cyclophosphamide for remission induction. And the results of a long-term follow-up of this combined regimen shows that yes, the combined regimen leads to significant reduced risk of death, ESRD, and relapse when compared to either agent treated alone. So let's forget about mycophenolate in AAV, but this study in 2019 said that patients treated with MMF do as well, but they are associated with a higher rate of relapse. Now this term, do as well as, is, I don't know whether the pharma pushes the drug, MMF, rituximab, because there is nobody pushing cyclophosphamide. Now then MMF was studied for, is it useful for induction treatment of non-life-threatening relapses of ANCA vasculitis? And look at the figures. 6 months remission, cyclophosphamide is better. 2-year disease-free survival, cyclophosphamide is better. And 4-year disease survival, cyclophosphamide is still better. So these are the figures. Now, even in children, people are still talking about remission induction in 2022 with glucocorticoids and monthly IV cyclophosphamide. And if you have sicker patients, then you add plasma exchange, and then you consider rituximab. And some of the patients in this group, there are around 60 patients, they even received intravenous cyclophosphamide every 3 months. The consensus treatment plans for severe pediatric AAV also use cyclophosphamide remission induction regimes. And a study which talks about intensified B-cell depletion therapy in AAV compares rituximab, cyclophosphamide, and methylprednisolone pulses to oral cyclophosphamide and steroids. Both arms have cyclophosphamide. They show no statistically significant difference between these strategies. And the expert opinion of Dr. Gullivan, he says how best to manage relapse and remission in organ-threatening situations. You reintroduce glucocorticoids and you combine them with cyclophosphamide or rituximab. He prefers rituximab because most of the literature is talking about higher infections, and you yourself said that this is like the rising sun, but I'll talk about the rising sun too. Now, we all know the NIH trial. The median follow-up of patients here was 7 years, median follow-up, and there were 5 arms. And 3 of those arms had cyclophosphamide. One had oral cyclophosphamide, and one had oral azathioprine and cyclophosphamide in reduced doses, and the third one had IV cyclophosphamide every 3 months for median duration of 3 years. And this proved the efficacy of cyclophosphamide and transformed the survival of patients with lupus nephritis. And by this time, in 1986, they had shown that this was especially useful in those patients who had chronic histologic changes on kidney biopsy. And these patients did not have an increased risk of infection, hemorrhagic cystitis, or malignancy. So where is the data coming from that patients with cyclophosphamide have higher infertility, the hemorrhagic cystitis? I know where it's coming from, and I'll talk about it a little later. So we know the 10-year follow-up of the low-dose cyclophosphamide DLNT trials, and they give us a lot of confidence in managing lupus nephritis with lower doses of cyclophosphamide. And the very pivotal RCT from Dr. Rathi in PGI Chandigarh, which showed that the complete remissions rate was similar in low-dose cyclophosphamide and MMF group. And yes, we have data from our institute, which is a registry data with all its policies, where we also showed that cyclophosphamide did better and much better in the published literature. And the flaws, I thought, were because there is a study which talks about adherence to therapy in lupus with respect to especially hydroxychloroquine, but the results they showed was that if you're unemployed, if you're young, and if you're using no steroids, then you're very likely to not adhere to therapy. And this is what I thought was happening to patients in our registry, where we recorded very low outcomes with MMF. You've talked about the Cochrane Library. The Cochrane Library 2018, the last word on proliferative lupus nephritis induction, says that MMF is better, but the evidence of certainty is low, and it included the possibility of no difference because the diamond there is touching the line. The adverse event is accepted. And what is the summary of findings for induction therapy? So if you look at mycophenolate and intravenous cyclophosphamide as comparators, and you look at outcomes of complete renal remission, mortality, major infection, alopecia, ovarian failure, and then you look at the relative risks mentioned in this table, then you will see that the relative risks are in favor of MMF, but if you go down the list, they go down, they favor MMF, but it's not a very great effect size. And that is what is very important to remember, that unless your effect size is great and is related to the dosing that you give, the evidence for the certainty of evidence which you're seeing is very low. So I'll not go into this because of lack of time, but look at the 2019 EULAR guidelines for management of non-renal lupus. You have belimumab as green evidence and for moderate disease, and you have cyclophosphamide as grade C evidence, which means you don't have randomized clinical trials to support enough in non-renal lupus, but you know that if you use this drug well, then in severe lupus, you know you can do wonders with this drug. And please see where rituximab is also in this guidelines for non-renal lupus. Now, in 2022, data from 61 repeat kidney biopsies over an interval period of 4 years showed that the only variable which associated with decrease in chronicity index was the use of cyclophosphamide. The biggest network for pediatric rheumatology used Eurolupus, surveyed its pediatric rheumatologists, and 135 of 185 of them who responded had prescribed cyclophosphamide in the last 1 year. So do you want to take it away from them? And when they looked at treatment of refractory lupus nephritis and renal flare in juvenile lupus, then they showed that rheumatologists were more likely to prescribe rituximab than nephrologists who used cyclophosphamide therapy as a single agent in these patients. So, yeah, we do have some long-term information on the use of rituximab in LN, like we need a drug which maintains remission. But these are data coming from 2006, 2010, and both these papers put together had 30 patients of lupus with refractory lupus nephritis. Rituximab was added to them, 100% response was achieved, 60% relapsed, and needed further doses of rituximab, and the median duration of follow-up was 2 years. Why are we not following these patients for a longer time and showing that, yes, rituximab leads to continue? Now, okay, let's use belimumab in lupus. Use it because it is proven to have reduction in the disease activity. It reduces the amount of steroids you need, but it makes no difference to the health-related quality of life, to the number of serious adverse events, and to deaths. Look at the BLISS Calibrate trial, done between 14 and 19, published in 21, in patients with refractory LN, previously treated with CYC or MMF. It did not have a benefit when it was added to a combination of rituximab and cyclophosphamide as maintenance therapy. So your search for a new drug keeps going on. And now the BLISS lupus nephritis trial, adults with biopsy-proven lupus nephritis, in addition to standard therapy, belimumab, yes, increased the primary efficacy renal response, which, if you know, is a changed goalpost, changed in the middle of the trial, and it was more likely to have a complete renal response. 2 years later, in a commentary by Dr. Liz Lightstone and by Dr. Fury, who conducted the trial, in a subgroup analysis, they showed that it was most effective in proliferative lupus nephritis. And look at this goalpost they are now using. It reduced the time to a 30% or a 40% decrease in GFR, but no apparent benefit of adding belimumab to those who were receiving cyclophosphamide or azathioprine. So in the BSR conference this year, there was an abstract by, again, Dr. Liz Lightstone of the rituximab fame, and she said she was discussing the role of cyclophosphamide in lupus nephritis, and the words she used were, it is a venerable drug, it is a practical option in developing countries, and it is a great tool in the armamentarium. And Sapan, you actually lost the debate 15 minutes ahead of this session when Professor Ingrid mentioned this trial, which showed that rituximab was not better than cyclophosphamide in improving the FVC over the first primary endpoint of 24 weeks and in many other secondary endpoints like the 48 weeks. And this was a trial which worked on patients with severe progressive ILD related to scleroderma, inflammatory myositis, or mixed connective tissue disease. And rituximab was not superior to cyclophosphamide, and even the physician global assessment. Let's not talk about cough, which you derided, but which is an important symptom of ILD, but a physician assessed global disease activity score favored cyclophosphamide. And so rituximab is an alternative to cyclophosphamide. Look at MDA5 positive ILD, which is rapidly progressive ILD. 400 patients, and they used a combined, they are recommending a combined therapeutic regimen which includes cyclophosphamide. Look at the expert opinion on treatment of scleroderma-related ILD. Yes, agreed, it is number 4, number 3, but it's not dying. You've talked about ovarian failure and cyclophosphamide. Yes, actually in the first study, the GOLD study, they showed that patients of lupus who were naive to cyclophosphamide also had a higher incidence of premature ovarian failure than the general population. Using cyclophosphamide definitely added to the risk, and the AMH, which is a marker of ovarian reserve, was definitely lower in patients exposed to cyclophosphamide than not. But you are a very wise physician, Sapan, and you can use your drugs well. So you can use a low dose of cyclophosphamide, which does not impact ovarian reserve. And the data which talks about ovarian failure, hemorrhagic cystitis, bladder cancer, myelodysplasia, lymphoma in cyclophosphamide use comes from the beautiful study, the landmark study on AAV vasculitis published by Fossey, where he described the course of 158 patients, and they used cyclophosphamide at a dose of up to starting with 4 milligram per kg body weight, reducing it on remission achievement at 3 or 6 months to 2, and decreasing it by 25 milligram, so that if you look at the dose that cyclophosphamide that they use, it would be like 50 grams in a year. And you are being asked to use 3 grams, 6 grams, 9 grams. That doesn't mean that you have been able to bury cyclophosphamide. So I would end by here by saying this, that yes, there are new kids on the block, and cyclophosphamide is likely to be pushed off center stage if the young rheumatologists take over from the older rheumatologists, but it will remain a niche for itself. And SAPAN, when the consciousness and evidence-based medicine transforms you divinely, the necessity of discussing death of cyclophosphamide will not arise. Thank you.
I think the stage is now set for the mother of all battles. On one hand, we have SAPAN PANDYA, who used the journey through the political landscape of this country, and then we have LIZA, who showed the, I think, superstar of all times, Amitabh Bachchan. And just like the political landscape of this country is unpredictable, so also the therapeutic landscape. And we have the rheumatology pundits sitting here. What the exit polls will show, will it translate into reality, we do not know. We will first have a rebuttal from SAPAN before we open it to the House.
Thank you, sir. I have a rebuttal for almost, देखो ये भी गिर गया इसके दुख में माइक का. For almost every, how many?
SAPAN, you have 5 minutes, and then we would like to involve the House in the debate.
So, Professor LIZA sounds like Fountainhead's Howard Roark, and there is this quote in Fountainhead where his girlfriend says that, to be with you, why do I have to be against the world? So, मैं रिटुक्सिमैब या बेलुमैब से इतना प्यार नहीं करता जितना मैं साइक्लोफॉस्फामाइड से नफरत करता हूँ. That is the issue. So it's all against one. I know it was a difficult debate for you, but that's the crux of the story. And talking about Amitabh Bachchan, Sachin Tendulkar was replaced by Virat Kohli, who is now being replaced by Surya Kumar Yadav. The point is they are being replaced. It's not that who's going. And thanks for the comment on spirituality about death, but I do believe in the physicality of death, and that there's no life after that, all of us know. So coming to the more specifics, you talked about meaningful departure and extinction. I think those are just sort of Shashi Tharoor semantics, and I think it's basically death or not using the drug. The cost of, so I did calculate the cost of cyclophosphamide, and the problem is you can't give 3 to 6 months of treatment and then say, abhi mera kam ho gaya, abhi jao. It has to be maintained by something, and you can't keep giving cyclophosphamide. So you maintain with something, and I wrote an SMS to Bijju from IPCA कि मुझसे सबसे सस्ती rituximab कितने में दोगे? And that was without saying that I'm in the debate, and I can show you that. So it comes to about 8,500 milligram, which is 6 months. 8,000 is what? About 1,000 a month. That's not a big deal at all. If you count cyclophosphamide maintained by MMF or even Azoran, that becomes to about 5 to 6,000 of 6 months treatment. So I've done that part, and the Gujarati in me always knows about the cost. Don't worry about that. You said about 2 doses of cyclophosphamide with rituximab. Well, I showed that if you induce with cyclophosphamide, there are more deaths. So it's just rituximab alone, and you don't need to add cyclophosphamide to that. Obviously, there are more infections and deaths in those. Talking about the 1986 study, I think that was long back. We don't have options to Braga, and you had options like Sharad Pawar and those things. So I think there was a time, and you counted 7 years till 93. So when we didn't have these new drugs which had come. So there's no point in even comparing these two eras. And then coming to the Cochrane thing, you only helped me by saying that the MMF was better. The relative risk you said are low, but the point is that to the individual patient it is 100%. When you tell the patient कि भैया इसमें तुम बच्चे नहीं कर पाओगे, तुम टकलू हो जाओगे, तुम मर भी सकते हो, तुम्हें cancers हो जाएंगे, nobody is going to take that drug. That's the problem. To the individual patient, it's 100%. So, and then you talked about the anti-malarian hormone. The data of the side effects that I said, the percentages that I quoted are there on up to date with all the references. That these are the percentages, that mean percentages of these patients will get these toxicities. And the fertility, all of us know that depends on the age. So if it's a young age, it may be still fine. In old age, you still have to, in slightly towards a 30, 40-year-old, it will be important to not give them cyclophosphamide in these patients. And coming to the CTD ILD part, you talked about only rituximab. As I said, my debate is not just about rituximab. I have so many friends. It's you have only one friend, that's the problem. So just accept that, that's going to be the problem. And as I said, what after six months, so you could use tocilizumab, MMF in these patients, you could have used all of these. And so after all of these points also, let us be honest that before a couple of years, even I was a fan of the Congress party. But now, after these 2 years, in the last 2 years, with all the evidence that has come in for the various other parties, with the jackknives being very promising, the Aam Party coming in, I think it is time to vote for the other parties and let the party die in peace. Thank you.
Well, we've listened to both sides, and now the question is, should we read the obituary of cyclophosphamide, or will the phoenix rise from the ashes? And it is the rheumatology pundit sitting here who will decide. It is now open to the floor. Yes, please. Specific points, and then we'll take, like in all democracies, a voice vote.
Yeah. Well, even though it's specific, but he has brought some politics, he's brought some senior actor. So I feel both are good, and be aware that next meeting is in Hyderabad. And all of you are welcome and support Hyderabadi.
That's a Hyderabad bias. South Indian bias.
Great debate, Chairman. As usual, SAPAN Pandya tried to hide by bringing some colorful faces, which he used to hate earlier tremendously, and tried to do plainly Operation Lotus by killing a nice drug. Before I met Paul Baker and brought him to this country, when I started my rheumatology practice in 1983, the only drug I knew was cyclophosphamide. And my helper in difficult situation was Michelle Petrie. Even today she swears, whatever the printed material, the use of this thing, it's not going to die its natural death. Whatever Operation Lotus you do, it will rebirth again and it will be remain as a useful drug.
To this, meanwhile, can I request the organizers, there are some drum beats there. We don't need drum beats in the... Yeah, I mean, yes, Sakir.
Dr. Sakir from Bhubaneswar. My question to a point for Sapan sir. If I remember correctly, the up-to-date data on cyclophosphamide toxicity is from the studies in breast cancer and not in rheumatological conditions. And on a lighter note, if you have so many friends, why would you like to throw out your old friend?
Sakir, we could not get that, and can you just repeat?
The joke needs to be repeated.
You know, we are competing with another extraneous factor, and
the cyclophosphamide data is from...
Yeah, that I got it. The second part was?
Second part, you are having so many friends, then why are you throwing out your old friend?
Yeah, please go ahead.
So actually, during my presentation, I was going to say sorry to Mahendranath sir for the photographs that I put up. I obviously knew that there will be some comment to those photographs, but I didn't say it because I thought that would not be right. So disregard his political part and consider if somebody wants to say something, yeah. Loud. No,
Mic, please switch on the mic. Dr. Suma Balan.
The mic doesn't favor cyclophosphamide, so.
Maybe you can come to the other mics there. That microphone is perhaps not working.
I say let's support women power. The thing about rituximab, which has been valiantly brought to the fore here, is that we forget the hypogammaglobulinemia that it brings. And believe me, I've seen children come with severe infections even 2 years after they stop rituximab for nephrotic syndrome and having an artificial hypogammaglobulinemia, which needs a lot of expensive treatment. And while it's a great drug in many ways, it has its problems too. So it's not as wonderful as it's portrayed. So go with Liza.
Yeah.
We'll have, yes, only 2 comments now. Yes, Shenoy.
Yeah. See, there are plus and plus. Thank you, Sapan sir, for that lot of entertaining talk. But we should remember that the last 15 years I've been in rheumatology for a shorter time than many of you. But still, in last 15 years, in 2007 or 8, if a patient comes, the amount of preference for cyclophosphamide definitely has decreased over years. So I think it is not the end, but I think it's the beginning of the end. Thank you.
That was SGPGI bias, if I may say.
Well, the political scene now is hotting up. So we have a South Indian bias and we have a SGPGI bias, and let's see what
for the Gujarat bias.
A women power.
I need to vote in for Gujarat bias as well.
I'll allow just 2 comments because we need the House to vote on it. Yes, please.
Now, I think since the comments were about influencing the outcome, I thought we have to pitch in here. If you really want to have women power, I think we should go against cyclophosphamide, because that does infertility and lots of things. And all the side effects are more for women in cyclophosphamide when you are using it for autoimmunity. I understand what Liza ma'am said about cancer. And the second point is about hypogammaglobulinemia. The main factor when rituximab causes hypogammaglobulinemia is when it's used with cyclophosphamide. People have done this trial that the single agent rituximab, when used for autoimmune conditions in the doses that we use, the incidence of hypogamma is very low. Thank you.
Vijay, and then we'll have to put it up to the House.
One question to Dr. Sapan. I really enjoyed the talk and I favored your talk. But thinking about what we are battling now is relapse rates across all indications you showed. Is there a real difference between relapse rates in cyclophosphamide versus rituximab? Is my intriguing question.
So I'm not able to listen properly because they are already celebrating my victory. But going back to your question, so I showed the data on mycophenolate and cyclophosphamide. It was similar in terms of glucose relapses, whether you use mycophenolate or cyclophosphamide. And with rituximab also, while we don't have long-term data as yet, but whatever data we have, that has shown that the relapses are similar. In the case of GPS, when you induce with cyclophosphamide, they are in fact lesser. They use that in relapsing disease. And lupus nephritis, if you use MMF with tacrolimus, the long-term data show that the relapses are going to be similar. MMF alone, you have to go up to 3 grams. All of us know that.
All right. Please be brief.
Yeah. I am Sandeep Kansarkar from Pune. So, in favor of Sapan sir, I just want to say, this debate we are having because every time in control arm we are having cyclophosphamide, and that is being compared with another drug. But I think time is not far when we will not see cyclophosphamide in control arm, rather the existing drugs will be in control arm, then probably the time may come and Sapan sir's dream may come true.
No, I have to say something to that. You may support him for whatever reasons, but the cyclophosphamide arms have been similar effect sizes. So you're not going to see the end of cyclophosphamide. You may wish for it.
Now the people power will decide. And may I put it to the House, those who are in favor of cyclophosphamide, please raise your hands. No, I think we have. And those who are against cyclophosphamide.
Don't raise 2 hands.
I think that vote would be null and void. So I think the House has shown it is in favor of cyclophosphamide, and this is where we rest the case, overwhelmingly in favor of continuation of cyclophosphamide. And I must thank the 2 worthy opponents of a very spirited debate and the House for joining in. Please give a big hand to both the debaters.
We'll wait for the funeral for the next couple of years.
Very good.
I must thank you, sir.